Welcome, everybody, to the Playing Games podcast, episode 22. And today I'm joined by Dr. Karen Ginn. Dr. Ginn, how are you doing today?
Well, thanks, Juan. And you?
Good, good. Thank you for joining us on an episode. We're excited to get started. But first things first, as always, we like to start off with an introduction on your background and your experience in the field, so people who may not know your name or have not come across your papers have a better understanding of what your role is over here and, your understanding of the literature.
Okay, well, I trained as a physical therapist many years ago, and after a short time in full-time practice, I then started teaching anatomy at the university. And over the years, I developed with colleagues functionally clinical applied anatomy courses for health professionals, particularly in the area of musculoskeletal anatomy. And in doing that, and in teaching clinicians at both the undergrad and postgrad level, it became clear to me that there was quite a lot of misunderstanding of the anatomy, and it was being applied in the musculoskeletal area in a way that did not seem consistent with the anatomy that I knew. And that was particularly true of the shoulder. So when I decided to do a PhD, again, much later in my career, I chose to run a clinical trial looking at conservative treatments for shoulder problems. And one of them was designed to improve the neuromuscular control about the shoulder. And during that, it became clear to me that we didn't really know what we meant by that and what we were doing. And so subsequent to my PhD, I went back to the laboratory and we developed with some other colleagues who were familiar with EMG. We developed a lab looking at normal shoulder muscle activity during movements with the aim of looking at people with shoulder dysfunction in the future. As it turned out, 15, 20 years later, we're still looking at the normal shoulder and finding things out. And I didn't understand this at the time, but it's more difficult than you might imagine to be able to record from people with dysfunction, although we have developed a methodology we think we can use. And using what we learned from that, took it back to the clinical field. And we've been looking at clinical trials, looking at the efficacy of conservative treatment and surgical treatment for shoulder problems. We've been looking at the validity of various clinical tests that we use, looking at some exercises. We started to look at stiffness around the shoulder and what that really was, cortical changes associated with shoulder pain, and ultimately, the last few years, we've been looking at sort of ergonomic things that can help people with at risk of shoulder problems. That's probably a summary.
There we go. Sorry, I just muted my mic. But that's awesome. So you have a lot of experience going over also hands-on, but also behind the scenes on research, right? Because I think that's an important skill to have.
Yes, I have tried to bridge that gap between, well, not gap, but that space between the sort of academic world, particularly in something like anatomy, and the clinical world, where we're using anatomical principles often as the basis for our clinical reasoning in terms of how we treat problems. And I've always done some part-time clinical work. I still do at the moment.
And do you think it's helpful using these findings and your experience with the research itself and then applying it into the clinical practice? Or do you also think there's this not guessing game, but also things that it's hard to explain with research, so you kind of just have to eye it out in a way?
Well, yes, I think you take the research and you see how it can be applied. I think that, I learned as much from the clinic as about what I should maybe investigate in research, as I found in the lab, where we can take that back to the clinic to improve our assessment and treatment of shoulder problems. And I think, yes, sometimes it takes a while before you can find a purpose, a clinical purpose for some of the findings we found. But I think we shouldn't discount that. We just keep it there until we know more, and then maybe can understand what we found better.
I think that's a good way to put it. So moving forward, I want to get started with the two topics on or popular myths, I guess we could say. Well, first one being the supraspinatus during abduction. I believe you have a paper on that, maybe a few. But there was this misunderstanding where people would think that the first 15 degrees, I think it was, the supraspinatus would initiate abduction and then the deltoids take after. I think that's, am I understanding that correctly?
That is what I think a lot of people believe, but it's totally incorrect.
So you want to go on and explain why maybe we believe that at first, or what could have possibly led people to believe that at first, and then maybe see, okay, well, now we know why that is incorrect.
Well, it's difficult to explain why it's that particular misunderstanding has lasted so long. And most anatomy textbooks will say that supraspinatus initiates abduction. So it's perpetuating this issue. Over 50 years ago, people anesthetized the nerve to supraspinatus, and every one of their subjects could both initiate abduction and could move through full range abduction. So in 1963, we had strong evidence that it did not initiate abduction. So this myth has lasted a long time in the face of significant, powerful, I think, scientific evidence. And subsequent to that, we and other people have looked at supraspinatus through abduction. Our paper on the initiation of abduction showed that supraspinatus is active. Yes. Oh, sorry. Before I say that, what does initiate abduction mean? Does it mean you turn it on and then as you go through abduction, you turn it off? That was one idea people had. What we used as a criteria was that you had to turn on the muscle you thought was initiating abduction before movement occurred. And if you're going to say it initiated abduction, it had to turn on significantly earlier than any other muscle. And what we found was that supraspinatus turned on before the movement occurred, but so did the other rotator cuff muscles that we were recording from, infraspinatus subscapularis and deltoid, and all the upward rotators of the scapula that would accompany abduction that we were recording from, trapezius and serratus anterior. They all turned on before movement started, and there was virtually no significant difference at the time they turned on. So how can you say supraspinatus initiates abduction when the whole pattern of muscles required to produce abduction turn on at the same time and before movement occurs? And subsequent to that, what we've done in looking at abduction through range is that supraspinatus turns on and is active throughout all abduction at the same levels as the other rotator cuff muscles. So on any criteria that you look at, supraspinatus does not initiate abduction. It's active, but it does not initiate abduction.
And I mean, I would also hear people say that there'd be people who have like supraspinatus damage there, but they would still be able to perform abduction. And they would kind of say, like, you could kind of indicate that the supraspinatus isn't the main initiator because some people would be very damaged with that or have that muscle be very damaged, and they will still be able to initiate abduction perfectly fine.
Exactly. Yeah. So clinical evidence also supports that. But I think we have to, one of the issues here is we try and allot something to one muscle anywhere in the body, but let's just talk about the shoulder. This muscle does that. That never happens at the shoulder. Muscles work in teams to produce the movements and provide the functional stability at the shoulder that we need. They never, ever, ever work in isolation. And when we think we're testing them in isolation, we're wrong. So what I said was that what we get to initiate abduction is activity in all the muscles that we were recording from, that is the abductor, deltoid, the rotator cuff muscles, and the axioscapular muscles that produce upward rotation, which accompanies abduction. All of them are active at the same time to initiate abduction and to take abduction through range.
And that was with the paper, that was the findings from your paper, correct?
That
Or
was
do
the
you have a few
findings from a
papers?
number of papers that I have summarized there for you. And not just our work. I don't think I could quote other people's work on EMG, which would say the same thing. The supraspinatus is active and active at quite high levels during abduction under load, as are all those other muscles that I mentioned.
Do you think there's some limitations with using EMG to confidently conclude that we are more correct now than before?
The EMG has limitations, yes, but I think that evidence is pretty conclusive. We always use the same methodology in our studies. When you're looking at initiation of movement, we can look at when the muscle is active. And we use a lot of indwelling electrodes because that's the only way to validly record from many of the shoulder muscles. And they cause some activity in the muscle just because they're placed there. But we looked at when the muscle was 3 standard deviations more active than baseline levels. And we were recording movement at the same time as the muscle activity. And with its limitations, which I acknowledge there are limitations of EMG studies, I don't think that would be a criticism of these studies where we looked at initiation of movement. I think we can conclusively say that it does not initiate abduction. And it's about time we looked at the body of research that supports that and stop amplifying a myth that the first EMG study conducted in 1943 states in the paper that supraspinatus does not initiate abduction. So it's about time we started listening to the research in that area, I believe. It's conclusive.
Might you know the mechanism why it could not initiate abduction per se? Could it be that the physical size or the cross-sectional area of it is too tiny for it to initiate it? Or is it pulling, like, is the line of pull not in the optimal direction to initiate it?
I think, again, you're trying to look at a muscle to initiate a movement at the shoulder. That's not how it works at the shoulder with the muscles. When you want to produce a movement, you recruit all the muscles that are required to produce that movement. And the movement requires that you move the humerus. So you recruit muscles that will move the humerus in the direction you want. When you do that, that puts displacing forces on the humeral head. And so you must, at the same time, recruit rotator cuff muscles to counteract that displacement. And when you contract muscles that go from the scapula to the humerus, like rotator cuff muscles, like deltoid, they put displacing forces on the scapula. And at the same time as you contract those scapulohumeral muscles, you must contract axioscapular muscles to hold the scapula in place and then eventually to move it into the rotation that is required. You cannot, it would totally mess up the shoulder if you recruited individual muscles. And so you must recruit the pattern, the muscle pattern that is required for whichever direction you're trying to move in.
And that's part of why the shoulder is so complex, right? Because there's so many muscles all working together, like force coupling, work synchronized in a synchronized manner, to be able to perform the movement in an optimal or efficient fashion, correct?
Well, it's complex in that it requires to
Hello? Can you hear me? I think you froze a little bit. Are you able to hear me now?
Can you hear me, Juan?
Yes, I can hear you now. Can you hear me? There, can you hear me now?
I can.
Okay, I could cut that part out. But sorry, where were you leaving off?
The point I was trying to make was, you seem to be asking me questions focusing on one muscle in that pattern. So supraspinatus working during abduction, and that, why can't it initiate abduction? And the point I was trying to make is, the muscles that initiate abduction are all the muscles that are required to produce the particular movement you want. So the one that, whatever muscle that you say, we're going into abduction, so we need to turn on the abductor, which is deltoid. When you turn on the abductor, you put displacing forces on the humeral head, which requires you to, at the same time, to turn on the rotator cuff muscles to stop that displacement. And when you turn on deltoid and rotator cuff, you put translating forces on the scapula. And therefore, you have to turn on axioscapular muscles, or sometimes people call them scapulothoracic muscles, to hold the scapula in place. And eventually, as you go through movement, these scapular muscles then have to rotate the scapula to accompany whatever movement you're doing. All those muscles have to be on. You cannot turn on one of those and expect that they have a particular role. They all have to be active. And it's true of every movement at the shoulder.
Okay, so then with textbooks, you mentioned they have an incorrect understanding, or they explain an incorrect understanding of the supraspinatus. How would you correct that in a way? Like, how would you say the function of the supraspinatus is, at least when it's working in synchronicity? Like, would it be more an external rotator or anything like that?
Yes, it is an external rotator. Its primary action, that is, the movement produced when it shortens, what textbooks describe as muscle function, their action, is to be an external rotator. And it is part of what I call the posterior rotator cuff. I actually did bring my scapula in, so I thought I might try and explain. So if you look at the scapula, it has like this is the ventral surface, the anterior surface against the ribs, and the posterior or dorsal surface on which the spine is attached as well. And basically what you have on this posterior surface is, sorry if I turn it, this way, are three muscles: supraspinatus, infraspinatus, teres minor, sit on the back of the scapula. These all function together. They're all external rotators, and they do the same things in terms of preventing displacement. On the other side, of course, you have a single muscle, which is the subscapularis, the internal rotator. And our studies consistently show that supraspinatus works with the other muscles on the back of the back of the scapula to produce external rotation and to do its stabilizing roles in conjunction with those other muscles on the back of the scapula.
Would you say that the orientation of the humerus or the arm bone relative to the scapula will dictate the relative action of the supraspinatus?
Well, yes, I think that, depending, obviously you've got superior fibers on the back of that scapula, which would be supraspinatus. And so they probably at different points have a greater ability to produce rotation torque than others. But that would be similar to subscapularis. The upper parts of subscapularis, even though it's not a different muscle, they probably work slightly differently in terms of producing internal rotation in different parts of range as, say, the lower fibers of subscapularis. It's just that it's one muscle. We don't, anatomically it's one muscle, and we describe it as such. On the back of the scapula, anatomically, we've got three muscles, but they all have very similar actions and functions.
So moving on, I think this understanding of synchronicity is going to be important here as the muscle is working on the shoulder. There was a paper talking about the anatomy and function of the trapezius muscle by Boduk. I might butcher that.
Boduk.
Yeah, and so what people have been doing with that paper, or there was this huge debacle saying that this paper shows that the upper traps do not elevate the scapula because, one, they don't attach to the scapula directly, and two, the physiological cross-sectional area of it is too tiny to do that. So the main contributors to scapula elevation are the levator scapulae and I believe the mid traps. I think that's what they concluded.
I think that's a misunderstanding of this paper. And really, when you elevate your scapula, just feel your upper trapezius. It's active. Would you not agree?
I mean, I would think so.
I don't know if
I don't know sensation.
Do that. You can feel it. What they're describing is, it's how does upper trapezius elevate the scapula? Because most of the fibers are transverse. Yeah. And a lot of upper trapezius attaches to the clavicle. Some of it does attach to the acromial end of the scapula, but a lot to the clavicle. And the clavicle and the scapula work together. The shoulder girdle, functions as a unit as well. So what they described was a mechanism whereby upper trapezius can produce a medial force on the clavicle, pushing it into the sternoclavicular joint where there's a great big disc that can take that pressure. And by doing that, elevate the clavicle, which will elevate the scapula. Okay, so it's just the mechanism whereby upper trapezius can elevate the scapula, not directly, but via its connection with the clavicle and through the sternoclavicular joint. Did that make sense?
Yeah, and that's kind of what I thought too. I would always think that just because a muscle doesn't attach to a certain joint, it could still do some kinematic link chains. It could still influence movement at that joint indirectly through movement of other joints, right?
Well, and particularly through, between the clavicle and the scapula. The only functional movement we need from the scapula is rotation. And it's a movement we cannot do independently. If I ask you to rotate your scapula, you can't unless you move your humerus. So it's totally connected. And how do you move you rotate your scapula, and what that creates is rotation in the clavicle because they're connected by a ligament. They are strongly connected by a ligament, which produces the only functional movement, well, not the only, but the main functional movement of the clavicle, which is a rotation, posterior-anterior rotation. No muscles do that. It's created by the conoid ligament, which attaches the clavicle to the scapula. In other words, you move the clavicle, you will move the scapula because you've got this strong ligament that makes them work synchronously, I guess. Mm-hmm.
And the upper traps from that paper show that they do involve movement at the clavicle to then elevate the scapula, right?
Exactly. They pull the clavicle in, which causes it to rotate at the sternoclavicular joint, elevating the clavicle, which will elevate the scapula. And I think what's very interesting about this paper is that it explains why we have such a consistent, strong, thick intra-articular disc at the sternoclavicular joint. It allows the forces, muscle forces that move the upper limb to not be directly connected to the cervical spine, that a lot of it goes through the clavicle into the sternum and then can be dissipated that way. It's I think, a very interesting paper to describe how the body is protecting the cervical spine as you move the upper limb.
So then I guess we agree saying that it's incorrect to say that the upper traps are not involved in elevation of the scapula. But would you consider them to be, I guess, the prime, I'm not a fan of the word, but a prime mover of elevation, or do you think there are other muscles contributing more than the upper traps because of their small size or their fiber type?
Yes, I think levator scapula is in a much better position to elevate the scapula, but it's not very big. And so, you can produce amazingly strong contractions through your upper trapezius. It's a big muscle, yeah? And you need them, and not necessarily to elevate, because elevation is not a functional movement of the scapula. What the upper trapezius fibers really do through the clavicle and the scapula is that they elevate the lateral end of the scapula. Okay. And so they are really involved in the force couple that is producing upward rotation of the scapula, which we need to elevate the arm. But that's not why they're strong. You don't need to be strong to produce elevation of the scapula. Sorry. We don't need to be strong to produce rotation of the scapula. It's a very thin bone. I think you'll see mine's got a hole in it because it was so thin. It's very thin. So you don't need a lot of force to rotate it. And I would argue strongly that's the only functional movement you need of the scapula. But so why are the scapular muscles so strong? They're strong to act as stabilizers against the forces produced by muscles that go from the scapula to the humerus to move and stabilize the shoulder, so that those muscles don't displace the scapula on the thoracic cage. They're strong because they need to be strong to counterbalance translating forces created by deltoid rotator cuff, teres major would be another one of those muscles.
So I'm glad you brought up stabilizer, because there's also this contention that stabilizer muscles don't exist, or people can't properly define stabilizer muscles. So when you talk about, or would you say, how would you define a stabilizer muscle, or would you even consider a stabilizer muscle to be a proper term of a muscle, or just based on like their function that they're doing for that specific task?
I think it's not difficult to explain, and is definitely a function of muscles. So one way of describing a stabilizer muscle, it is a muscle that is active to prevent movement, to stabilize a base so that other muscles have a stable base from which to work. Yeah. And that could be that they stabilize a base against a physiological movement. So if I take the wrist and I want to use my fingers to do this, the finger flexes past over the wrist, and if I don't stop it, the wrist will flex as well. Now, I may not want that. So if I want to flex my fingers against a wrist in a neutral position, I will have to contract wrist extensors to prevent those finger flexes from flexing that wrist. That's a stabilizer function. It's what we mean when we say core stability. We are stabilizing our pelvis against movements of, let's say, the lower limb. But another way to say it is that they could prevent non-physiological movements at the joint. And I think this is what applies at the shoulder. So when you turn on muscles to move the humerus, those muscles will pull the humeral head out of place. Deltoid will elevate it, flexors will push it forward, extensors will pull it back, because there are no passive structures to stop that. No ligaments except at the end of range, a very loose capsule, and articular surfaces that are, do not contribute to stability. And so muscles that stabilize that humeral head against the pull of other muscles are stabilizer muscles. And in terms of scapular stabilizers, they're stabilizing the scapula on the thoracic cage against the lateral pull of muscles that attach from the scapula to the humerus, scapulohumeral muscles. Because when you turn them on, they can move the scapula, because even more than the humeral head, very little is holding the scapula in place except muscle activity.
So is their only role to stabilize, or could that change?
No. Absolutely not. So all muscles around the shoulder can produce, well, virtually all muscles around the shoulder can produce a movement when they contract. That's their action. So they can produce movements. So these muscles around the shoulder are performing multiple roles in all movements at the shoulder. Some of them are working as movers, prime movers or assistant movers. Some are working as stabilizers. Some are doing both. Some are also working as synergists to cancel out unwanted movements of other active muscles. And muscles can perform all those roles at the same time. And that's the complication of exercise around the musculoskeletal system. And I would say particularly around the shoulder, because muscles are performing multiple roles all the time. And as you change direction, the contribution to those roles changes.
So I'm gonna circle back a little bit on the muscle's ability to generate force within the context of the upper traps before moving on to how you say it's the most optimal movement of the scapula, which is rotation. I think it was. Um, I wanted to bring up one last point. I've heard that because the upper traps don't necessarily attach to the bones, they attach more to the aponeurosis or something like that of the cervical spine, that reduces their ability to generate a moment about a function of a joint or a bone to move.
Uh, it's one way of muscles attaching to bones. It's an aponeurosis. It's a flattened out piece of connective tissue. All the abdominal muscles do that. Latissimus dorsi attaches to the thoracolumbar fascia, as do many of the back muscles. And what it does is it allows them to spread their load, I guess, over a bigger area. So it is just another mechanism whereby muscles can produce movement. And certainly, the paper we mentioned before, the Bogjuk paper, it's looking at the fiber direction and trying to work out how it can produce movements based on its fiber direction and what force it can generate. And yes, it's spreading its load, but its fiber direction is still able to produce these forces and some torque. It's this paper is really describing how that muscle, upper trapezius or trapezius in general, with its basically transverse orientation, can produce rotation of the scapula and elevation, retraction, and depression, depending on which part you're talking about.
Because there's the descending fibers and, like you mentioned, the transverse fibers, right?
Yes.
But
Yes.
I think that from what I remember, the descending ones, there's not a lot of them, or they're not large.
Exactly. It's quite a small muscle, and it's sort of, if I can go to a clinical situation, one of the common exercises for people with shoulder problem is to give them depression exercises to strengthen lower trapezius so that they stop elevating. It will never happen. You will never, ever get lower trapezius strong enough to counteract upper trapezius. For people who are elevating when they shouldn't, what you have to do is get them to switch off their upper trapezius, because lower trapezius can never, ever get strong enough to be able to counteract upper trapezius. Their problem is not weak lower trapezius. Their problem is overactive upper trapezius.
So then, from a practical standpoint, how would people, when people try to grow their traps or train them or train their function, would you say shrugs may be the best way to do that, or would you prefer something like a Kelso shrug is when they just retract the scapula to train the traps? Or I've also heard of the monkey shrug where they have the arms overhead and then they do that to train the upper traps.
I would say two things about that. Why are you training a non-functional movement of these muscles? Okay, firstly, why are you teaching people to do movements that functionally they don't need in almost all activities? Okay, and secondly, I'm not sure how much your listeners understand about EMG, but when you're looking at EMG, you're looking at just the electrical activity in the muscle and how to interpret that, even in terms of how hard they're working compared to other muscles. You need to what we call normalize the data. You need a reference contraction that you can then say this muscle is working X amount of what we normally use is its maximal voluntary contraction. And then you can say, well, X muscle is working at 10% of its maximum that it can produce, and Y muscle is working at 5%. You can compare muscles, you can compare people, you can compare activities. And when we were doing this, when we were starting out on our EMG at the shoulder, we looked at movements of the scapula to try and produce maximal voluntary contraction. And we used shrugs and we used retractions. They didn't come anywhere near to getting maximum out of the muscle. When we got maximum out of trapezius, when we resisted the upper limb on a long lever. So, for example, we got the maximum amount of trapezius when we were doing, and do your listeners know the empty can test? So
I don't think.
Okay, so it is what am I doing? I'll try and show you. We're looking at a resisted abduction with the thumb down or in internal rotation, and you resist here at the wrist. So a long lever resisted abduction movement. That's what got the most out of trapezius. You want to strengthen your trapezius, do resisted arm movements. Okay. Recruit the whole pattern of abductors or flexors, which includes trapezius, resist them on a long lever. Don't elevate. Let them do their normal movement. They're getting strong because they are working very hard, probably in their stabilizer role, to hold the scapula still against the pull of all those other muscles.
And that happens naturally when we, let's say, are doing something like a deadlift, where we're holding the bar down and they have to resist that downward force, right?
Well, I don't know if it's a downward force from the load. It's the force from the muscles that are active that you're using around your shoulder. Okay, the muscles like deltoid and cuff and, all those muscles that go from the scapula to the humerus. You use those, you turn on your axioscapular muscles at a similar level of activity. So as you increase load, you get, say you're doing a deltoid raise, you increase load, you'll get more activity in deltoid. That's obvious. You also get more activity in, and it is, if you look at their percent maximum, MVCs, you'll get level in activity in deltoid going up, rotator cuff is going up in the same systematic fashion at similar levels as are all the axioscapular muscles are going up. The correlation between the increased activity in all those muscles is amazingly high, and they all increase activity in the same systematic fashion. Could I bring up something about muscle testing? Because I think it's relevant to our conversation. We have whole books on telling us how to test individual muscles around the shoulder. You are not testing individual muscles ever, okay? So I have to say that I think those books are misleading. That when you are doing a test, let's say for lower trapezius, and I think it's a test where you're up in some sort of elevation in prone, there's a number of them. But what you're testing is all those muscles that are active, and they're always at least one muscle moving the humerus, a bunch of the rotator cuff, and virtually all the axioscapular muscles are working. Then if you test painful or weak, you cannot attribute it to one muscle. You can't. It's just not what is happening. And it's misleading for us to think we're doing that.
And I think that's where a little bit of my misunderstanding also comes in, because from physical therapy books that I have, they would also say shrugs for upper traps or testing an individual muscle this way. And I think that kind of, it misled me in a way. So I think hearing this is like a new perspective on how to look at things.
Can I say that I think anatomy books are contributing to that, but it's because they are limited in what they can say a muscle does in a like a book, like it's a static thing. Muscles change what they do depending on the movement that you're doing, the body posture, the speed with which you're moving. Muscles will do different things. Okay, they will work harder or less, etc. And what we need to understand is what textbooks tell you about what a muscle does is one thing. It's the movement produced when it shortens in isolation, if you want the full definition of an action. Muscles never work in isolation, so it's never possible, and it's only one thing a muscle does. So we all think that upper trapezius elevates, and it does. I believe it does. But it also depresses if we do it eccentrically. So if we go slowly down in the direction of gravity, that's upper trapezius doing that, but it's lengthening to do that. We need to understand these roles that muscles play, and we need to understand that muscles never work in isolation. I would suggest anywhere in the body, but I definitely know at the shoulder.
I think a popular teaching tool right now is more so because anatomy is limited to 3D, or at least the books. anatomical books are 2D. And so when people look at them, they have this, like you said, limited perception on how these muscles work. So what I would see some teaching tools is like using rubber bands to dictate or to represent like a line of action of a muscle, and then showing how different changes on body posture can change how that muscle pulls, how it can function, how it may even completely change its original function depending on the position of the bone.
Perhaps. I'm not saying it couldn't be valuable. I think the biggest thing that I would say is to recognize you should not be looking at individual muscles, that muscles work in teams. And that's what we need to understand, because when one muscle does something in a team to do something that you want, it often produces things you don't want, and other muscles have to come in to counteract that. And so what I think we need to understand is that when we do a movement, we will recruit muscles that produce that movement, okay, whether it be concentrically or eccentrically. We will then recruit muscles to stabilize body parts in response to that activity in that muscle. And at the shoulder, we have to consider both the humerus and the scapula, because they both have to move to produce full range movement. And the pattern is pretty precise. So I think understanding that muscles play different roles in movement, that it's not an individual muscle producing its action, is what a muscle does, that they work in teams, they have to perform a number of roles. And I think we need to do that, need to understand that, firstly, to strengthen muscles, but also to develop appropriate rehabilitation programs to address the functions of muscles, like their stabilizer function, rather than just trying to strengthen them in their action. I think it's very simplistic, and I think it demonstrates a lack of understanding of the muscular system in general.
So you brought up that the natural movement of the scapula, I believe you said, was rotation rather than elevation, maybe protraction and retraction and protraction as well. What makes you say that that is the natural movement of the scapula? And using that knowledge, how would we apply that during our everyday movements, like when we're bench pressing or doing a pull-up or anything like that?
All right, so if I bring my scapula back now, tell me if this is making sense with me pretending I'm being a scapula. Okay, I'll bring the humerus in. All right, now this is not a matched pair. This humerus should be a little bit bigger. Perhaps that's a little clearer if I get out of the way, is it? Yeah? Yeah.
Yes.
Okay, so one of the things about, if I just hold the scapula still and roll the humerus, you roll the humerus on the scapula and you see I've now reached the maximum amount I can rotate, and I'm at about 30 degrees abduction, I guess. Yeah. So one of the things we could do is we could pull the humerus down and it will keep rotating. That could happen. But actually what happens at the shoulder is that you rotate and you get to about 30 degrees abduction, and then the scapula starts to turn so that it's available to that humerus to keep rotating. Now, I don't think anyone disagrees with that kinematic description of abduction, that in the first 30 degrees, it's mostly humerus movement, and then you start to get upward rotation of the scapula. And the reason you do that is to maintain contact between this very large humeral head, the ball, and the much smaller and shallow glenoid fossa. And that is optimal for the articular surfaces. But the other reason you do it is that the muscles that attach to the scapula, as you move it, you're keeping them in an optimal position to produce their actions and their functions. That's why we need to rotate the scapula. The pattern is very precise, and I think it's telling us that that's optimal for the shoulder. Now, why can we do these other movements? Because this is a really flat bone, and to rotate it, we've got to pull it from the edges, I suppose. So this is the midline on the scapula. You're looking at it from the front. So upper trapezius pulls in this direction, let me say, elevate a little bit and inward, attaches to the outer part of the spine. Lower trapezius attaches to this medial part of the spine, so it pulls the spine down. Put the two together, you've got the force coupled to produce upward rotation. So we want to rotate it upwardly or downwardly. And the way we do it is we have to coordinate the muscles that do these other movements, which we don't need to happen, to be able to do that rotation. And therefore, I would say that what we want when we want to strengthen these is not to do these not dysfunctional, but non-functional movements. We don't want to encourage those. We want to encourage normal functional contraction of this muscle. And that means in rotation. And given that none of us can rotate the scapula, none of us can do that independently, we're going to have to do it through movements of the humerus. And the more we load the humerus, the muscles that move and stabilize the humeral head, then we are going to have to contract these muscles that do the rotations that we want, but probably, well, I would say definitely, in their stabilizer role. The exercises we give are really related to people's understanding of what muscles they think muscles do, which is from textbooks, which are very, very, very limited in what muscles do.
So then for people who, let's say, go to the gym and do presses, a lot of them seem to overemphasize retraction when they're pressing and then protraction when pressing. But then others like to keep the scapula restricted. So they'll retract and depress and then keep it like that.
I wouldn't do either. I don't want it retracted. I don't want it depressed. I don't want it elevated or protracted. I want it neutral. Okay. And that's where it's meant to be. And so you want to do, so what do? We do a press because it's a pecs exercise, basically. That's what we think we're doing. Yeah. Well, it is, So you want pecs to work really hard to lift that load, make pecs do it. If you make the pec major work really hard, the back of the cuff will have to work equally hard to hold the head against the pull of pec major. And as you work those hard, you will have to upwardly rotate the scapula to the level you want. That is whatever level of rotation is required for that angle of flexion. And you will have to then hold it in that position against the very hard pull of pecs and the back of the cuff. You do not want, sure, these muscles are really strong. You'll lift more load if you do that, but you're not achieving what you want, which I think people want pecs. I think that's what they're after when they do that. And you're taking the load off them. This needs to stay wide, not protracted, not retracted, not elevated, not depressed, normal position. And you do your push-up, your bench press off that. And if you do that, you will find it much more difficult to lift the loads that you were doing because you are sort of abrogating, you're taking away the load from pecs by doing these movements. I would say they are not functional and they can lead to shoulder problems is the other thing that I would say.
So, but I feel like it may be inevitable for some people to completely eliminate some degree of retraction and protraction when doing something like a press, right? It's not like it's going to be perfectly still throughout the entire movement.
Why not?
When I try something like that, I feel like my shoulders are going forward unless I limit the movement or limit the range of motion to it. I don't know if that's just how my body looks like, so it looks like I'm protracting.
I think it's what you've learned, and you can learn not to do that. Okay, so if you go forward, yes, you get your arms a certain distance forward. If you want to protract, they'll go further forward. But why do you want to do that? You don't have to do that. It's purely, these are all voluntary muscles. You can teach people to do it without that. My feeling, my strong feeling, and this is, I guess, what you do in the clinic, is that people will do exercises incorrectly, often because, it's a way of avoiding the pain or something. Like there's lots of reasons. But, isn't it our job to teach people how to do it correctly? And I think then we have to understand what is functionally correct, because I think that's what we're trying to do. We're not trying to, functionally improve this system, in this case around the shoulder. And that applies to not just people with problems, but people who are trying to maintain good function around that area. And a lot of that, I understand is about body image and whatever, but I don't see there's anything wrong with that, as long as in doing that, we don't develop problems. And I don't know about you, but, the gyms are quite a source of revenue for therapists. People come from the gym having generated problems with the exercises that they're doing. I'm not saying everyone, and it's not super common, but it's not a uncommon way that people end up in physiotherapy practices for treatment for shoulder problems. All of that is trainable, and I think it is our job. I personally think it is our job to make sure that people are doing things as correctly as possible.
So then because I think a lot of this also comes from powerlifters who would retract in the press to be able to press maximally that super heavy, or weightlifters, or that super heavy weight. So they'd create this strong base. But then we have another side of people that'd be, well, we don't want to retract because at the end of retraction is elevation. And we don't want to elevate as we're pressing. So we want to just do depression because that creates more space in the glenoid cavity or whatever, and it would feel more natural to do that. And so those are like the two sides that I constantly see on how to press properly.
Well, I would probably say to you that what weightlifters are doing, and I haven't done anything with weightlifters, so I'm sort of guessing here, but you don't want to protract and you're about to lift a really heavy weight. So you've got to brace your scapula for that load, which means you will be looking at those muscles that hold back, before you lift. You don't want to come forward, so you stay back. But do we need to go that far back? I would say the functional position is that mid position where you are widest from side to side. That's the position, I believe, that will put the scapula in the best position to be able to then cope with the loads you're about to put on it from what you're doing with the muscles around the shoulder joint that are about to lift that load for you and stabilize that shoulder joint. So it's not, we don't want to retract and do it from there. What we want is to brace in mid position so that we're in an optimal position to do these. I would argue that functionally is probably a way to achieve better results. And that's a hypothesis on my part. I have no data to support that. But from the way the shoulder works, that would be a strong argument in terms of technique for weightlifters.
And so as we're coming to an end, because as we're talking about movement, I do want to bring up movements as like a pull-up, because now in that exercise, I do see a lot of people really emphasize that elevation at the bottom and then the press at the top to allow the scapula to move with the humerus. But also we see people like gymnasts who train isolation and movements like that, where they really just do one exercise of the scapula and just train like that to practice for whatever they're doing, or whatever movement they're doing. Would you say that's dysfunctional of them to just train isolation?
When I'm talking about not functional rather than dysfunction, if I can say that, there's nothing wrong with doing retraction. It's not going to hurt you. I just don't think it will contract the scapular muscles really hard. And it's not something we want to do in our functional movements. So I, again, would suggest that when you're doing a pull-up, the best way to do a pull-up is to use the muscles to pull you up without elevating, okay? And that will work the muscles that are doing, so it's the humerus that is moving to give you the range you want. It will work them harder. And all this is doing is really getting you higher, but in a non-functional way in terms of what you're doing with the scapula. I think that it will be harder for you to do if you don't do that. It'll be harder for you to lift your body weight. Okay, so that's one reason people do it, because it gets their body weight up there, because these are really strong muscles. But it's then putting the scapula potentially in not the correct rotation position, because you're using the upper part of the forcips more harder than you need to create the rotation, and therefore putting the shoulder joint at some risk. Yes. I would argue that we need to keep what we do at the scapula functional to get the strength in the other muscles that we're trying to strengthen. I think we're trying to do that. And that if you do that, you will strengthen these axioscapular muscles, because they must work in a similar level of activity in terms of their maximum to the other muscles that you're working. And that is functional.
Yeah, because I would see some people really overemphasize, like at the bottom of the pull-up, they would really just allow their scapulus to elevate to get a full stretch on the lat, and then at the top, they will just naturally come down to depression, and they'll really
And that,
emphasize those movements.
yeah, and that just brings me back to the right position for this. We need to put it into its right rotation position to do those jobs that I described before. And if you change that, then I would suggest it isn't optimal for the shoulder joint. And then, you have not aligned that rotator cuff optimally. You haven't positioned the glenoid fossa optimally for that, humeral head position, and therefore potentially put that joint at risk.
So to finish off, because I know we're running out of time here, I wanted to bring up when people are at the gym and they feel some shoulder pain, is there a way that physical therapists or maybe in research we find that we could find out that it's due to muscular pain, tendon pain, or joint pain? Is there like a way to test that, or is there any research to suggest how we can know that? Because some people might not know what it is, and then they try something and then it makes it worse. Like they might reduce or they might stretch all the time. I see a lot of people stretch to reduce tendon inflammation, but may not even be tendon. I don't even know if stretching does reduce inflammation that well for that.
So I think you certainly can get muscle pain, pain coming from what you've done to the muscle. But given that the shoulder muscles have the predominant role in stabilizing or in positioning, accurately positioning or stabilizing that humeral head and the scapula as well, I would suggest to you that pain and the pain, shoulder pain is this area, over the point of the shoulder and down into the arm. If you're getting that pain, I think it's joint pain. And I think it's joint pain because the muscles aren't functioning properly to support that humeral head or the scapula. It can be either side in the right position. And the joint is mechanically irritating itself because of a muscle dysfunction. And therefore, I would say that you need to look at those patterns that they're moving in. What are they doing that is aggravating, it is causing that joint not to be positioned in its optimal way and therefore is mechanically irritating itself. And that can lead to mechanical irritations of tendons. And the tendons that are often affected are the rotator cuff tendons. And the tendons of the rotator cuff are flat and they intermingle with each other. They are not tendons like these sorts of tendons. And I think, again, because they surround the joint, inflammation there is likely to be due in a lot of cases due to malpositioning of that humeral head, non-functional alignment of that humeral head. And therefore, because of the way the shoulder works, I would say you've got to look at the patterns of what people are doing. Yes, I would unload it a bit. Yes, I would look at the movement pattern. How were they moving? Are they moving in the way I've tried to describe? Scapula rotating, not doing other things. Yeah? And change that. And to do that, I think you have to decrease loads. I think it's increasing load too fast, that with the emphasis on increasing load, that leads to these non-functional movement patterns that lead to this mechanical irritation at the shoulder joint.
And how would you describe joint pain? Because I think when some people think joint pain, they're like, how can joints cause pain? Is it like bones on bone touching, which I don't think it is, but
there's lots of there's proprioceptors and there's pain receptors around a joint. Yeah. So, but there's also other structures. This humeral head sticks out a long way from the glenoid fossa. There's only about, at best, a third contact of the humeral head with the glenoid at any one time. And so it can bang into acromion processes, it can bang into coracoid processes, all these other things which are bony, surrounded by periosteum, pain-producing structures. We've got bursae around the shoulder that try and minimize the effect of that mechanical irritation. But when they fail, because there's too much mechanical irritation, then you get swelling and an inflammatory process. Of course, there's pain associated with that. You can feel around a joint. And you can, a little bit, we can't get too close, but you'll feel tenderness around the joint, which is telling you, I think, that, there's some sort of problem with the alignment of these bones causing a mechanical irritation.
And could some of what you described be what's known as impingement? Because I know there was some research saying that impingement is not real, or it's not what we think it was before. I don't know if you looked into that before.
I haven't looked into it, but I probably, and this is very simplistic, but I think three things go wrong at a shoulder. The bones are not well aligned during movement, and so you get a mechanical irritation which hurts. And I would call that impingement. Then you get other people where they get a pain, but it also feels like it's going to dislocate, come out, and I'd call that unstable. And then the others where they get pain and they get associated stiffness, a stiff, painful shoulder. And I think that describes most shoulder conditions. A lot of the diagnostic labels, many of the diagnostic labels we have for the shoulder are not useful. They don't tell us what's really going wrong. Most of them don't tell you about muscle dysfunction. And if you don't know about that, I don't think you know what's going wrong with a shoulder. And they don't drive treatment. Surgeons will offer surgery, physios will offer exercise, rheumatologists will offer injections, because that's what we've got to offer. Okay, so whatever the label, we offer what we've got to offer without too much understanding. Well, that's what we do. And so I think these labels, the diagnostic labels we have are, and this is not just my idea, there's papers written on this that say that they're not just not helpful, they're leading to inappropriate treatment. Rotator cuff tears, so we have to repair the tear. Well, no, not necessarily. If someone's older, they've probably got tears in the side that's asymptomatic. So we've got to be careful about these diagnostic labels. And I think we have to, a bit like low back pain many years ago, we have to pare it down to something we understand. And, with back pain, it was non-specific low back pain. We described all these conditions that used to have lots of labels. I think maybe we need to do that with the shoulder and then build up a new system of describing shoulder problems where we understand the mechanism behind the cause of the shoulder problem.
I think that's a great way to end off the podcast there. I guess as a little summary, I don't know if there's anything you want to finish off by telling the viewers, maybe like a little conclusion of the upper traps, maybe optimal shoulder position. And I guess if we're looking at shoulder pain, the first thing to look at is, are we moving properly?
Yes, I would. And that sort of comes down to the movement patterns, the recruitment of a bunch of muscles to produce any movement around the shoulder. And that is the way muscular system works, and particularly around the shoulder, because it has such a major role in stabilizing the bones, the joints and the bones in that area. And stop looking at individual muscles around the shoulder. You are never exercising individual muscles. Keep it functional. Make your clients do what you want them to do, not what will allow them to lift more weight and feel good about themselves if it's going to be a non-functional movement that's likely to cause them problems in the future.
And just as a quick follow-up, by functional movement, what do you mean by functional? Because sometimes that can be very discrete.
So the kinematics of the shoulder says you move the humerus and you move the scapula. And the movement of the scapula that follows movements of the humerus is rotation, and it's in a particular pattern, which we understand quite well in flexion and abduction. It needs to be that way. When you start abducting for the first, 30 degrees or so, it should be mostly humerus movement. Does not matter what the scapula does. It doesn't do very much. In flexion, it's about 60 degrees. After that, it should be sort of a synchronous rotation of the scapula with the movements of the humerus. We don't know so much about the functional behind back movement, which is a functional extension. And functional, it's what we use in normal activities is what I mean. But I'm sure there's a pattern there as well that's similar, concise and precise, like the pattern in flexion and abduction. That's what I mean. Move it the way the mechanics is telling is optimal for it in terms of how we're positioning the bones. that will be telling us that we're using the muscles correctly.
Well, Dr. Ginn, thank you so much for your time. I hope people will be able to watch this and have a better understanding of proper shoulder health and shoulder movement, and maybe it could benefit them in the gym if they try to apply this understanding over time, because I know injuries take time to heal, or pain, who knows. But again, thank you so much. Do you know where people could find you if they want to read more of your work, or are you on any social media platform?
There is I have a course that people might like to do in English and in French. I can send you that information of how they wanted to go there. It's an online course which really goes through the functional anatomy and applies it to a clinical situation, applies it to the clinic in terms of assessment and exercise prescription, and there's a case study in there as well. And that's really a summary of what I've said. I do a few podcasts every now and then, and I have a few podcasts with companies in Europe. I can send you those links if you would like to add them to this podcast.
Yeah, absolutely. I could actually add them down in the caption below if anybody, if there's any physical therapy students interested in taking your course. I think that could really benefit them.
Good.
But thank you guys for watching, and I will see you guys on the next episode. I hope you guys enjoyed this.
Thank you, Anne.